Rajim. Bismillahir Rahmanir Rahim. Qul huwallahu ahad, Allahus samad, lam yalid wa lam yulad wa lam yakul lahu kufuwan ahad. Sadaqallahul Azim. So we have this very important session today, and the title of session is the cancer and infection. So we tried to cover major areas in this field that we got some articles and papers presenting. So first of all, may I request Professor Dr. Amreen to please come on the stage as a chair for this the session, and Dr. Amir Afzal would be joining us soon. Enters that the allotted time is total 15 minutes. We will inform you at 2 minutes before the end of the presentation, and we'll request the presenters to be on time. So first presenter is Professor Dr. Moeen, and he would be talking about the emerging epidemic of So is a multimodal approach in retinoblastoma management. Sir.
Thank you very much, Ozair, and thank you very much for joining us in the session. Amir Afzal Sahab, sir, aa jaye upar chair. Aa jaye. So the treatment is retinoblastoma, which we are going to discuss today. So welcome, Professor Mahmood Yaz. And so the multimodal approach to retinoblastoma. So retinoblastoma is a disease which is cancer affecting the eye. So there are certain recent advancements in the disease which I'm going to discuss how it works and what we know about the disease and what we are doing in Pakistan. So you can see it affects about 1 in 15,000 live births, and the significance accounts for less than 3% of the cancers. But the important thing is, if you do not treat it early, you're going to end up sort of losing the eye, not only the eye, but also the life of the patient as well. And you can see the figure over here, the prognosis, the survival rate is supposed to be more than 95%. But this 95% is for the Western population. For Pakistan, probably it is going to be the opposite, which we see over here, because the patients do come in, but when the patients, you tell them that you need severe treatment with chemotherapy, or you need to remove the eye, or you need to go multiple sort of treatments, the patients get frightened and they go on for alternative treatments. Sometimes their other relatives don't allow the treatment to be go through. So that is why there are barriers to the treatment of retinoblastoma. So this is something which is very characteristic of retinoblastoma, and that is a white pupillary reflex, or which is called a leukocoria. So if a child is there, if you're taking care of a child, then probably the one thing which you should be very wary of, if the pupils look white, if the color in the center is white, that tells you that the one diagnosis which you have is a cataract. It can be a congenital cataract. It can be retinoblastoma, which is a tumor. It can have a retinopathy of prematurity, which is something which you get the detachment of the retina in those patients. And it warrants immediate special referral, and the red reflex is shown over here, which you see. The other things which it can present is the eye being misaligned, going inward or outward. The patient can have inflammation on pain, especially in patients if the disease spreads otherwise. Poor visual outcome, and then advanced disease, you can get orbital invasion or spread. Before we start on the clinical features, we'll just go on to see, is it a hereditary disease? Yes, this is a hereditary disease, and it is autosomal dominant, and the tumor suppressor gene is the RB1. And the Knudsen two-hit hypothesis is very important to understand, that the carrier cell usually has one gene knocked out, but in malignant transformation, you need both genes to be knocked out. So you get two types of retinoblastomas. One is a hereditary retinoblastoma, and the other is a sporadic retinoblastoma. So the prevalence is 40% for the hereditary one and 60% for the sporadic one. And this hereditary one, the first gene is already knocked out in these cases. As you can see, the first gene is already knocked out, but in the other, the non-hereditary or the somatic cases, the problem should occur in both genes together, so which is not very common, but if it happens, the tumor suppressor gene, that is going to cause the problem. So it can be well differentiated or can be poorly differentiated. If the photoreceptors tend to get formed, it is called these Winter-Steiner rosettes. The important way how you can diagnose is you can use a direct ophthalmoscope is probably which is shown is not the treatment of choice. We use it an indirect ophthalmoscope to see this the tumor which we have. But I think the diagnostic tool which you use is a B-scan ultrasound, and the characteristic feature which you are seeing in this patient over here is calcification in the eye. Calcifications are very important or a diagnostic feature of retinoblastoma, because whenever you see these patients, you cannot just go in and get hold of those tissue and send it for biopsy, because whenever you're going to go inside the eye, you have the risk of spreading that tumor. Even if we have to go inside to do intravitreal chemotherapy, still we will need to come out and put a cryoprobe so the tumor cells do not come out of the eye. So this is, I think, one of the diagnostic features which we use is the B-scan. Usually we use an MRI scan, probably does not show calcification, but now they've got algorithms in which you can show calcification much better. X-ray or CT scan especially is not preferred in a hereditary retinoblastoma, because you can get a trilateral retinoblastoma in which you get retinoblastomas on both eyes and also get a pineal blastoma as well in these patients. Usually, if you stage the disease, so these are the sort of the grouping of disease. So there are stages, but usually now if it's confined to the eye, we'll just use the grouping of retinoblastomas. Number one is, you can see the tumor cell is small, which probably you can see over here. If it becomes greater than 3, then it is called group B. Then you can see it forms seeds over there, and the seeds are localized, then it is group C. And the seeds have come into the vitreous cavity, and outside this is called D. And E, when it becomes bigger in size, no visual potential, glaucoma or optic nerve extension. So we need to understand this is a tumor of the photoreceptors of the eye, and it is going to spread, majority spread. It takes the easier route, it goes through the optic nerve into the brain. The other is hematogenous spread, and it's going to go into the bones. And this is the major spread which you get, and in the end then multiple organ involvement occurs as well. So the treatment regimen which you use is observation, chemotherapy, and then focal therapies, brachytherapy, external bead. I'll just go through them in detail as I go forward. Chemo reduction with cisplatin, vincristine and etoposide will give sort of 6 cycles at 3 weekly intervals. The patients get a lot of reduction of the tumor, and at this time we need to understand one treatment is called neoadjuvant therapy, that you need to reduce the tumor before giving any surgical treatment. So chemotherapy is very important, and it's become the first line of treatment now to reduce the size of the tumor, especially because which of the tumors do you think we get over here in our country or city? Because I'll show our data from our hospitals, we tend to get more E or D groups, which you see over here. It is not very common to see A or B. A or B we will see in the other eye. A, the worst eye, is probably going to have an advanced disease, and the other eye does not have that disease. So here you can use tumor regression brachytherapy is when you apply the radioactive plaque on the sclera and you treat the tumor. If the tumor is small, then you can do just laser. 3 millimeter का size उन्होंने इसी वजह से रखा है, because that can be treated with laser therapy in those patients. So intra-arterial therapy is something which is a new treatment modality at which you go in and do a focused chemotherapy with melphalan or topotecan, and that goes at the back of the eye. So we can think of the treatment strategies which are available for smaller tumors. If we go back, for the smaller tumor, grade A, you can just go in and do a laser over here. And for group B, probably you will end up using sort of chemo reduction and downgrade the tumor and then use it. If you get seeds like this in like C and D, then you can use intravitreal chemotherapy along with systemic chemotherapy is required. And if you go into group E, which involves the whole of the globe, then you're going to go into enucleation or removal of the eye. I'm just going to show you an entity which is called intra-arterial chemotherapy. This is from the internet, so just the contributions are going to come at the end.
Prior to the procedure, a nasal decongestant, oxymetazoline, is administered to reduce the blood supply to the nasal passages. After the induction of general anesthesia, femoral artery access is obtained and intravenous deployment is administered. Utilizing fluoroscopic is advanced to infiltrate carotid artery at the level of sleeve shape. Under roadmap guidance, a microcatheter is advanced over a microwire beyond the ophthalmic artery portion. Selective catheterization of the ophthalmic artery is then performed by slowly retracting the microcatheter until the tip engages the origin. Supraselective angiography is then performed to confirm the position of the microcatheter and assess the hemodynamic flow patterns of the ophthalmic artery. The chemotherapeutic agent, melphalan, is then infused through the ophthalmic artery over a 30-minute period. The microcatheter position is assessed during the infusion by intermittent fluoroscopy. Enhanced chemotherapeutic delivery to tumors. A successful treatment avoids enucleation.
So the advantage of this treatment is that it would avoid, sort of reduce the chances of enucleation. You don't have to come in and go in for chemotherapy, that strict chemotherapy. That was on, and I was there in Lahore General Hospital. Dr. Lubna was working with me as SR over there, and we were able to do a lot of cases with intra-arterial chemotherapy. You can see the same thing being done live on a fluoroscope over there. The guide wire is being passed and going to go through the common carotid and then going to go up, and then once this is the fluoroscope, it shows you that everything is ready over there for the treatment, and then you would, this is the guide wire going up, doing this chemotherapy, the major thing is you take that guide wire up, and then once it goes up, you do take it up to the level of the ophthalmic artery, and then you can see this guide wire goes up and you're curling it up so that it goes onto the first branch of the this internal carotid, which is the ophthalmic artery, and when it goes in, you can go in and do a fluoroscope and then check if it's actually gone into the right area, and once that is done, you can inject the dye, which takes the melphalan, which takes about 30 minutes to inject. So you have to go there, and you need to repeat 2 or 3 cycles of this therapy to get the result. So this is just that. So this was our study in 2019 when we did, and so we are a case series of 19 children, median age of 12 months, with bilateral disease in 73% with male preponderance. And you can see over here, the group A, probably the classification which we get was 10.5, and group C was more there because we were getting more referrals coming in from different hospitals. So we were getting early disease over there. Systemic intravenous chemotherapy, laser, cryo, intravitreal, melphalan and ophthalmic artery chemosurgery was being done, and globe salvo was achieved in 8 out of 19 patients and 42%, and obviously 100% in the group A. And group D and E, we were not able to salvage the globe, so we had to do enucleation in those patients. And then there was another clinical patterns and outcome of retinoblastoma. In this, we did 47 patients from 2017 to 21, so 84 eyes. The mean age at presentation was 26.5 months, so you can see it's about 2 years. And the male and the females were more over here. You can, and bilateral disease in 37% and 6.3% had family history. 85% presented with leukocoria and proptosis in 9.5. And patients do come up with huge fungating lesions over here as well. Here you can see the disease classification, Group E. Now we've got more data over here. Group E is 42.9%. And probably the 33% we are getting is some of the patients of Group E, the other eye affecting, is coming up with those figures which you see. The treatment modalities which you used was intraarterial chemotherapy with melphalan, intravitreal melphalan as well. So this was intraarterial, and then going inside the eye as well. Either melphalan or topotecan was being used, laser photocoagulation and cryotherapy to consolidate the lesion, and enucleation and exentration. So some people might have Group E disease, might have sort of patients in orbital spread as well. So if you do a chemo reduction, you are able to reduce that tumor and then try enucleate that tumor at an easier level. So tumor regression was achieved in 54.8% patients, and enucleation exentration was done in 42.9%. So as I showed you in the start, internationally the figure is 95% success rate, but we are doing very poor, and the important thing for us to understand is to educate the people who are getting it. And patients with hereditary disease, we need to sort of tell them that the patients needs to be screened a lot of times to get this. And 82% regression in Group B and 96 in Group B. So the smaller, the earlier the disease, the better the regression you get in these patients. Post-treatment complication, cataracts, ischemic chorioretinopathy, especially in patients with intraarterial chemotherapy. Whenever we're giving that infusion, you can get constriction of the ophthalmic artery and produce constriction or ischemia over there. So it's very important to do that. So intraarterial chemotherapy significantly improved outcomes and reduced needs for enucleation, and early diagnosis was very strongly recommended for this. So in conclusion, retinoblastoma is a curable disease if diagnosed early, and with newer modalities of treatment, the patients have to go through less of toxic therapy and they can get better visual recovery and globe salvation. But early awareness and early referral can improve outcomes in countries like us. Thank you very much. Those patients or get that patients, we're trying to develop them, but it is still a patchy start at the moment, but I think that is the future way to go on that thing.
Another quick question. Once you've done the treatment, what do you offer for aesthetics or plastics, or give them cosmetic?
Yes, we do. I'm sort of oculoplastic surgeon by profession as well. So we do enucleation, we sort of put prosthetic eyes. The problem which we get is the implants which we use over here, they're more lower cost, which are the PMMA implants, but the hydroxyapatite implant or the Medpore implants, they are pretty expensive. But still, they do get a good response with that. The only thing which is the motility probably might not be very good on those. But usually, initially when we used to do these treatments, people would just, earlier when I came over here in 98, that time people would just do an enucleation and then have a radiotherapy done, and you would have that ugly looking eye seen for the whole of the life. The patients would survive. But then with these chemotherapy and everything coming up, we are able to save that eye. In that sense, we don't need to do radiotherapy, we just do chemotherapy on those patients. And they have got a good survival once they come in the good bracket, and once we remove the tumor with about 15 to 20 millimeters of the optic nerve, and if the optic nerve is not involved, we usually do get a very good outcome. But if it is involved, then probably they get a poor outcome.
Thank you very much, Professor Moin, for this very informative presentation about the prematurity retinopathy. Now, I welcome you all the dignitaries and the guests on the second day of the 45th KEMCA-UK. Now, the second presentation is online presentation by Professor Junaid Sarfraz Khan, who is the Rector of Health Services Academy, and his topic of discussion is a very pertinent one, and that is the breast cancer screening plus global perspective with contextual realities. So we are just arranging the thing, setting up the things, and he'll be starting his presentation in 2 minutes.
To be among such great academic minds at this very important scientific mood today. My name is Professor Dr. Junaid Sarfraz Khan. I'm a breast cancer reconstructive surgeon, and I have a fellowship from the Royal College of Physicians and Surgeons Glasgow, as well as the College of Physicians and Surgeons Pakistan. I also hold a double PhD in medical education and a postdoc in medical education from University College London. I am the Dean of School of Health Professions Education, Research and Entrepreneurship, and the Pro-Vice Chancellor and Director Academics at the Health Services Academy in Islamabad. The objectives of my presentation today are going to be to review global breast cancer screening models, to compare organized versus opportunistic screening models, describe current state of breast cancer screening in Pakistan, highlight the burden of breast cancer and breast diseases in Pakistan and South Asia, identify low-middle income countries' specific challenges related to breast screening and breast screening models, and also to propose contextual, feasible solution of breast screening in low-middle income countries and especially in Pakistan. When we look at the global burden of breast cancer, we find that it is the most common cancer among women globally, accounting for 2.3 million new cases annually and 685,000 deaths worldwide. Out of the 685,000 deaths worldwide, 70% of breast cancer deaths occur in low-middle income countries. And late stage presentation is the key determinant of mortality. And as you can well imagine, the high number of deaths related to breast cancer in low-middle income countries is because of late presentation of these cases to healthcare delivery centers, and that is a growing concern. That has been a growing concern for a very long time, and more importantly, this data is about 3 years old. So perhaps things are even worse than this as we speak. Accurate data is not available in Pakistan, but what data is available from cancer registries like the Shaukat Khanum Cancer Registry or the IARC Globocon 2022 shows that Pakistan has the highest breast cancer incidence in Asia. And when we just sit back and try to fathom that statement, it is a very worrying sort of statement, and 1 in 9 Pakistani women are at risk of developing breast cancer in their lifetime, and it is estimated that around 90,000 new women develop breast cancer every year, and majority of them present unfortunately at very late stage, which as we have already discussed is a determinant of mortality. So the later they present, the difficult it is to manage that cancer and the higher the mortality rate. Breast cancer accounts for more than 25% of all female cancers in Pakistan. So with this backdrop, why does breast cancer screening matters? We've already discussed, and we all know that the later a cancer presents, the more difficult it is to save the patient's life. So early detection of cancer means that it is in a treatable stage and it can be managed easily with more cost effectiveness. It improves the quality of life and survival, and it enables breast conserving surgery. We sometimes believe that that is probably not an issue in a country like Pakistan or in other Muslim countries, but believe me, as a breast cancer reconstructive surgeon, it is an issue. Women who do develop breast cancer and they come for surgery, they and their spouses are looking for breast conservation as well as reconstruction, and the earlier the breast cancer is detected, the lower the mortality, the better chances of breast conservation, the improvement in quality of life as well as the rate of survival, and a better a better cost of healthcare delivery for these individuals. So when we look at the various global screening models, we find that they fall into 5 major categories, including organized population-based screening models, opportunistic screening, risk-based or stratified screening, clinical breast examination-based models, and lastly, hybrid or phased models which are preferred in low, middle and income countries. So this is the global view of the various breast screening models available worldwide. So let's look at these models one by one. And the first one is the organized population-based screening model, which is being practiced in countries like the United Kingdom, Canada, Australia and Sweden. And it is a government-led model that targets women between the ages of 50 and 69, because this is the age where there is the maximum chance of getting breast cancer. And so it targets women between these ages. And the model, in this model, mammography is required every 2 years. There are national registries and recall systems, and there is data available. But one of the issues related to this model, an issue that low middle income countries might find as challenge, is that it is a high cost model and requires a lot of infrastructure demand, but it definitely leads to a significant mortality reduction. So considering if a country is willing to spend money, this is the model to go for. The second model is the opportunistic screening model. It is a model that is practiced in the United States of America and certain parts of Europe. And in this particular model, screening is offered during healthcare visits. So obviously, as you can understand, if screening is offered during healthcare visits, there are issues with equity. So affluent populations tend to get over-screened, and there is no defined population denominator. It's physician initiated, and there is a mammography or ultrasound only, and there is a high risk of missing underserved women. So there are pros and cons of this model, but as you can see that it differs significantly from the organized population-based screening model which is practiced in the neighboring country like Canada. Now, another screening model that is an emerging model in high-income countries is the risk-based or stratified screening model. And screening intensity is based on the age, the family history, the genetic risk, the breast density, uses of artificial intelligence and risk calculators, and it is a cost-effective model, but it is data-intensive. So one of the features of this model is that one has to have quite accurate background data available, which is an issue in low and middle income countries, because in these countries, one of the issues is of having accurate data and then data that equitably covers the entire socio-demographic landscape of that population. So yes, it is a model that is emerging as a model of preference in high income countries, but it is something that will be difficult to sort of integrate in a healthcare delivery system in a country like Pakistan. Now we come to a model that we can adapt here in Pakistan as well, because it is a model that is being followed in low and middle income countries like India, for example, and Bangladesh and Sri Lanka. And this model is based on an approach that of whose infrastructure is already present in Pakistan. For example, Pakistan has rural health centers and basic health units available all across Pakistan, which to some extent are also staffed as well, and then they have lady health workers and similar sort of workforce available in the country as well, with different nomenclatures. And these that workforce and these women can actually perform these breast examinations, clinical breast examinations in these sort of outreach areas, and then refer cases which they suspect of breast disease and breast cancer to district headquarters or larger healthcare centers. It is a stage shift towards earlier disease detection and management. It is cost effective and is acceptable in conservative societies like Pakistan. So what is the status of breast cancer screening in Pakistan? We all know that there is no national organized screening program in Pakistan, and mostly it is an opportunistic and urban center based screening. So sometimes there are screening centers which are in private healthcare delivery systems, and women might go and get themselves screened. There is a socio-cultural sort of inhibition towards getting themselves screened as well. There is little awareness of breast cancer and breast cancer diseases and their early detection, and the role that early detection could play in the management of breast diseases, including cancer. And all these factors you sort of unite in increasing not the burden of disease, but actually the outcome of that disease and the healthcare facilities that these women can actually get. And there is also a weaker cancer registry coverage in Pakistan, and whatever data is available is also not based on equity. It does not cover in majority of the cases, the underserved women of Pakistan as well. The large majority of these initiatives are taken by NGOs like the Pink Ribbon, for example. And when we look at key challenges in Pakistan and other low and middle income countries like India, Bangladesh, Nepal or Sri Lanka, they all fall into three main categories: system level, socio-cultural and economic. And these categories are presented here in this slide. So when we look at why mammography-only models fail in Pakistan, and we also look at the previous slide, we identify that there are socio-cultural issues in Pakistan as well, which are also present in other societies. But in Pakistan, women, as in other societies, are afraid of the diagnosis of breast cancer. They do not have enough knowledge about what breast cancer sort of means and what would be the outcome of that breast cancer, or if there is treatment available for breast cancer. It is sometimes considered as a taboo, and women do not want to be diagnosed as breast cancer. Working as a breast cancer reconstructive surgeon abroad in the United Kingdom, I also encountered women from the Caucasian races and quite sort of professionally accomplished women who were also afraid of being diagnosed of breast cancer, and they kept their lump with them without disclosing it to anyone within their family or to their general practitioner for months and years before they presented in very advanced stages. So this phenomenon is worldwide, not just specific to Pakistan. But in Pakistan also, there are other issues like a younger age of onset, for example, as young as 40 years or even earlier. And this is because there is an incidence of denser breast tissue in Pakistan. Then there are issues related to high cost and limited availability and poor rural access and inadequate coverage. So direct transplantation of high income countries' models in Pakistan will not be feasible. So presenting a contextual solution for Pakistan, I believe that a phased hybrid model will be most suitable, which also offers community awareness and self-breast care as well as self-breast examination. Community-based examination by trained lady health workers and nurses, targeted ultrasound and mammography, especially targeting high-risk populations, referral pathways to cancer centers and mobile screening units. And as I understand, there was a time when in Punjab especially, and still there were mobile mammography units that were deployed all across Punjab, and there must be some data available and in the government of Punjab which would show the incidence and the utility of those mobile screening units in the entire province of Punjab. Also now that the digital health and AI technologies are advancing, that can also be integrated with this system, and that could also help in the early diagnosis and better management of breast cancer and breast diseases. But at the end of the day, I think the most important thing is to develop public-private partnerships and pilot programs before national scale-up. We also need to strengthen national cancer registries, and that can only be done if digital health is integrated within the entire infrastructure of healthcare delivery within Pakistan. There has to be a national breast cancer screening policy, and we need to integrate screening into primary healthcare and task shifting to nurses and lady health workers, especially those individuals who are employed at the very basic levels, the grassroots levels of healthcare delivery in the basic health units and the rural health centers. They can be a pivotal role in early diagnosis of breast cancer and breast diseases in women in Pakistan. And let us not forget the role of artificial intelligence in early detection of breast cancer, in its risk stratification, and we can also use it for teleradiology, especially for rural areas, and digital tracking and recall systems can also be established. So there is a lot that can be done through artificial intelligence and integrating digital health with artificial intelligence and early diagnosis, which could reduce the burden of diagnosing breast cancer from radiologists and shift it to artificial intelligence, so that artificial intelligence can actually work as an assistant to the radiology team, looking after the early diagnosis of breast cancer through this national policy. So what are the key take-home messages? Breast cancer is a public health emergency in Pakistan, and this is not going to change whether we acknowledge this statement or not. It is an emergency and should be treated as one. And one-size-fits-all screening does not work in countries like Pakistan. We need to have targeted imaging of vulnerable population especially, and this requires strong political commitment and a lot of political will to pull it through. And I'm sure that will is now present in Pakistan, both at the provincial level and as well as the federal level. And if we can detect cancer earlier, this will be more cost effective in the longer term and will reduce the burden of management of breast cancer economically and financially from the government side as well. So early detection just not saves lives, but it also improves the health expenditure indices on breast cancer disease management. These are my references, and once again I'm extremely grateful to the organizers of this very important scientific meet for inviting me here today for this talk. So thank you so much, and have a wonderful day today.
A well-intended and a very holistic kind of a presentation about the breast cancer, which is globally endemic, and as he has rightly said, that it's a national emergency, and it cannot be overemphasized that a very effective
hybrid model of screening has to be devised. So he is the Vice Chancellor of Health Services Academy, and he is going to present strategies for reducing infection in Pakistan. Thank you.
Bismillahirrahmanirrahim. Assalamu alaikum. Thank you very much. I'm an alumni of King Edward 1991 batch, and it's always nostalgic to come here and see this development going on. When we were here, this block was not here. It was a green belt, I guess, and a playground. And being in Islamabad, I was able to join the NCOC, the National Command and Operation Control Center of the COVID, and that taught us a lot of things in infection prevention. You know, the whole world learned something new about infections and the reaction of the people towards infection. This burden of infectious disease in Pakistan is roughly around 40% of mortality. So 60% is non-communicable disease like cancer, diabetes. You just listen to this one breast cancer thing. There is a huge burden of non-communicable disease increasing. Diabetes, you know, 33 million Pakistanis, hypertension, 25 million. Cancer, different cancers, they are all on the rise. But we are one of those few countries which have the double burden of disease. And what is the double burden? You are not able to control the infections, and the longevity and the chronic disease, they step in. And the burden of those chronic diseases, they keep rising. हमने कोविड में ये देखा कि there are infections who can affect the person, but there are infections who can affect the whole area, the whole cities, and the whole regions. COVID was one example. So there are a lot of things going on currently. I didn't deliberately didn't bring my presentation because there are so much, work being done on infections and infection prevention for the last, say, 60, 70 years. But currently, there is a new model which is, hopefully we will be disseminating in the end of December, which is the rejuvenated model of One Health approach. So there are some talks in this conference on One Health going on. So when we talk about One Health, we talk about zoonosis, which actually is the cause of a lot of new infections in the humans. The human health, the animal health, and the environmental or climate change impact on human health. All three phenomena are nowadays very active. Just to tell you very frankly that 75% of the new emerging infections globally, 75% of the new infections are coming from animal side, animal health. So there are viruses, there are different types of, infectious agents who are getting mutated partially because of climate change, but because of many other factors as well. The way we treat animals, the way the animals are moving from one to other place because of this development in the geospatial zones. And that gives a slight mutation, and that virus which was not affecting previously the humans, now the new infections, the new emerging infections, they are coming to humans. You can have so many examples which recently we got international level and national level epidemics. So what is the most important aspect of infection prevention strategy or infection control globally? The first one is to give some awareness about what is new going on, and you can understand that on the phone and TV and radio nowadays there is a lot of talk about this H3N2, the new virus which is behaving like COVID. And every other person, you must have seen in Lahore as well, every other person is having a different type of flu with serious chest infections, cough, and a lot of body aches, but less fever. So this is directly causing lower respiratory tract infection. It hits down the lungs, and it is like absolutely epidemic nowadays. And there is an advisory going on issued by my organization, the National Institute of Health. The Health Services Academy is based inside National Institute of Health. We have developed more than 150 guidelines during the COVID, and the COVID response of NIH and Health Services Academy Islamabad was appreciated by the global authorities. Pakistan was among the top 3 countries of the best response of COVID in the world. So we were those who could, manage that menace with very less funds and with human ingenuity and a lot of support from army, of course, bureaucracy and the regional, local level people. So the first one is to orient people about awareness. Why awareness matters? Because today, even in 2025, people still believe in the rural areas that TB cannot be cured. Still there are people, and I think I have met many healthcare providers as well. They are also of the view, no sir, this can't be treated, these drugs are not working, this is multi-drug resistance is common. So even now, this disbelief on the treatment which is available, they are not willing to take it. The second one is HIV and AIDS. You see this HIV and AIDS, again, is very common in the media because the kids are having it now. The women, the children, 5-year, 6-year children. Why? Because it was supposed to be a sexually transmitted disease in the past, but now it is clinically transmitted disease. In Pakistan, it has become a disease which originates from a health facility. Why? Because the bridging gap, the bridging population, which has gone to some areas where it gets that, the sex workers, the MSM, the drug users, and of course the jail residents, they are very high risk of getting HIV. They go to the same facility, they infect the facility, and when general population goes there, even a child goes there, the infected equipment, instruments, the needles, syringes, and a lot of other, things which you use in a health facility, it infects the children, the women, and those who had never gone into any illegitimate sex or other things. So it is not purely a STI. The bridging population has infected the general practitioners, instrument and equipment, the hospitals, mostly in the private sector, as well as in the public sector. It is also true for the dentistry as well. So recently in Karachi, in Ladkana and Faisalabad and many other areas, we found a huge number of young children, women who had never have had a history of having sex with any high-risk group. They got this HIV/AIDS. So the awareness thing is very important because still we need to tell people that HIV can be transmitted through different means, even by the use of a health facility, a blood, a dental extraction or an injection. So please take care of yourself when you visit a health facility. That is the highest risk zone nowadays for getting HIV, for getting hepatitis B and getting hepatitis C. The role of Healthcare Commission is very important, so we are also trying to link up with the Healthcare Commissions of Pakistan and trying to get some more elaborative checklist to identify the risk of communication to the population, not just the risk. And the same risk applies to the healthcare worker as well. So we are also working with the occupational safety of the healthcare worker nowadays. You see all these infections. The first highest risk person is the healthcare worker inside the facility who is dealing with these patients. So this is awareness level. The next one is testing and tracing, which is very less. We estimate that there are around 4 lakh HIV and AIDS cases in the country. You know how many are in the system? 80,000. So out of 4 lakh people spread around the country of HIV, Dr. Mohsin Saeed will come next. He is an expert in HIV/AIDS at Health Services Academy. And he just completed a survey of integrated biological behavioral survey of Pakistan. The largest survey of HIV/AIDS, hepatitis C, syphilis, and what was the fourth? There were 4 diseases: hepatitis B, hepatitis C, HIV, and syphilis. 4 diseases. Blood testing was done, and 2 tests of each individual were done of the sample. And we know now the determinants of these infections in Pakistan. So after awareness, you need to test and trace. The capacity is limited in the country. You don't test every blood, you don't test every woman, even in the pregnancy and afterwards. But we need to develop some public partnership models where we go for this testing and tracing. And then third one is the hardest one, which was very difficult in the COVID, which is quarantine or isolation of the person who carries that thing. So you do the awareness, you do this testing and tracing, and you identify this patient is HIV/AIDS or hepatitis C or TB even. You know, one TB case, it spreads, if not treated, it spreads 10 new TB cases every year. Minimum 10 new cases by one TB person every year. So you can imagine if there are prevalence of say 3 lakh or 4 lakh persons in every 100 lakh population, is a very high proportion. So they are spreading like anything. And they are not getting treatment. They are leaving the treatment behind in between. So that then the MDR is going on. So the third one is quarantine or isolation of those cases which we know, so that they are not able to spread this infection to any other area. And the fourth one and the last one is management, which of course takes adherence to treatment. There is a very poor adherence to treatment for HIV, very poor adherence to treatment for hepatitis C, for very poor adherence to treatment for even TB. And that needs a lot of legislation, a lot of rules and regulations, some strict measures. But whenever we do something strict, the people of human rights, the lobbies of those who talk about the independence of human liberty, they come up. They don't think about that this person is giving risk to so many lives outside by not taking care of himself. So he should be held responsible for at least taking care of himself, taking medicine, and at least stay isolated till the infectivity is gone. So in this case of infections, we have now, what we have done is we have developed One Health Secretariat at Health Services Academy. So what we are doing is we are working with the persons who are working in the animal health area, animal husbandry, livestock, in those areas, agriculture, the environment department. So the Prime Minister of Pakistan has designated task force for One Health, in which all the departments are directed to participate with the human health to limit the transfer of these diseases, to do the research of how to cater with these new viruses which are coming up. So the lead is with the human health people, the clinicians, and of course the public health professionals. The basis is in Islamabad. We are doing a pilot in Islamabad, but the next is Lahore. Hopefully we will be doing in the next year we will be coming to Lahore for this area of collaboration between these intersectoral collaboration. The Almada Declaration 1978 asked for intersectoral collaboration, which is still not there. The human health, the medical science, this work alone without the participation of animal health or environment or anyone else. The doctors in the hospitals, the public health professionals in their offices, they all work in silo. But today, because of these infections, the 75% emergence of new infections from animal and environment, it is very much important that we collaborate together. We have a combined dashboard. If something is happening in the animals, new viruses are coming, we should also know so that don't get transmitted. So there is a very high level integrated dashboard of environment department, agriculture, livestock, fisheries, and of course human health, based inside National Institute of Health. 30th December, the Federal Minister of Health is inaugurating that, and hopefully when I come here next time in any other event and exercise, I will be able to give you some success stories, some positive things that how did it work. So this is something which the case is going on, and hopefully we will be able to tackle it like it is needed. And it was a real pleasure, sir, thank you for coming here, and thank you very much. Thank you very much all.
What are the strategies, or is there a national policy devised for the occupational hazards, being the health professionals? There are so many residents who have been,
Actually,
needle stick injuries.
Very limited time, I did mention the occupational safety because in the era of such a high level of infection, the highest burden is the nurses, the doctors, the lab technicians, and of course the OT person. And if you don't do proper testing of everything, definitely we are the first one to get this. Occupational health and safety, there is a model which is known as HealthWise, W-I-S-E, HealthWise. You can note it down and you can check it. International Labour Organization has entered into an collaboration with Health Academy, and we are now training the health providers and the managers of the health providers. देखिए ये आपकी जो नर्स है या आपका डॉक्टर है ये खुद से अपने आप को सेफ्टी कर सकता है जब तक आपका एमएस डीएमएस को ऐसा सिस्टम ना क्रिएट करे कि आपको बचा सके
सर एक मर्तबा हो जाए फिर
हाँ क्लिनिशियन वो उसके लिए वो पूरा हमने सिस्टम बनाया हुआ है चाहे वो सोशल प्रोटेक्शन मॉडल हो हेल्थ इंश्योरेंस हो उसकी ट्रीटमेंट दिस ऑल इफ इन्फेक्शन हैपेंस इट इज द रिस्पांसिबिलिटी ऑफ द एडमिनिस्ट्रेशन टू गेट ट्रीटमेंट इम्यूनोग्लोबुलिन चाहिए या आपको एंटीबायोटिक जो भी चाहिए वो आपको मिलेंगे
All right.
The first thing is prevention के लिए बहुत जरूरी है. तो ये health wise का हम करवा रहे हैं सारे hospitals में और ये हम secretary के through ministers के through इसको
Right.
कर रहे हैं. It is new. थोड़ा सा point है कि पिछले साल ही शुरू हुआ है.
All right, sir.
और it will be expanded to all government hospitals.
All right, sir. Thank you very much, sir. Thank you very much, sir, for helping us in a very difficult situation of COVID and dealing with it in a very effective manner. So now the next presentation is basically the sequel of Professor Shahzad's presentation, and it is being presented by Professor Dr. Mohsin Saeed Khan, and it is about the environmental trends in the infections of Pakistan.
Bismillah ar-Rahman ar-Rahim and Assalamu alaikum. Thank you very much, organizers, for inviting me, because it took me another 35 years to come back to King Edward's Medical College. Literally came here in December 1988 when I was a fourth year med student at a U Medical College, and privileged to be back here. I work at the Health Services Academy as a professor of global health. From Ayub to Health Services Academy, I am their first batch graduate, as well as then I went on to Karolinska Institute in Stockholm, where I did my PhD in health systems research. All right, coming to environment and health, and there is a mistake on this slide which I made by intent, and that is the spelling of the word environment. I did that by purpose because I wanted us to realize one notion, that when we talk of environment, we talk about trees, water, and air, and a lot of folk songs around it. That is no longer the case. The environment that we are now living in is now determining how the epidemiology of infectious and communicable as well as non-communicable diseases will process in future, how the health systems will respond to it, and lastly, how the economics of this, because as we say, the money makes the mayor go, so the econometrics of the environment is going to determine what is going to be the ultimate price that we are going to pay for it. We are also going to look at how, now we're not going to wait that for someone to get sick. The environment is not going to determine health. The environment is going to determine who is going to get ill before he or she reaches our clinics. When we talk of environment, as I said, it's not about trees and rivers and folk tales and love songs and temperatures. Environment itself is everything. It's all physical, environmental, biological, and it's external, which are all external to a person. And it's all related behaviors. It's no longer a backdrop to human health. It is now one of the most powerful determinants of how the health will shape out in the next couple of years. Globally, environmental changes are contributing and will contribute to about 6 million premature deaths annually, up till 2050. Air pollution itself will lead to 8.1 million deaths, and they led to 8.1 million deaths in globally in 2021. The household air pollutions, 2.9 million, and 95 million disability-adjusted life years were contributed only to environmental related morbidities. We will be looking at 1.7 billion cases per year of childhood diarrhea, and we will be looking at about 450,000 deaths under 5 children. Now, this is going to reshape pediatrics. Pediatrics not in clinics, pediatrics not in hospitals, pediatrics in our lives and the disease burdens that the environment will contribute. There is another thing that will come out, is heat, garmi. And it's not only the heat that we sweat and we talk about water and rehydration, it is leading to hours lost of work. How much work we cannot do. In 2024, according to the Lancet countdown and published by WHO in 2025, not only us in Lahore or in Pakistan or in Asia, but globally, we lost about 640 billion potential labor hours only in 1 year. And as I said, the econometrics, that accounted for about over $1 trillion of economic loss. Now let's come to Pakistan. That's where the fun is. 2021, about 250 deaths were attributed to air pollution only. 53,000 Pakistani children died, and they continue to die, over 50,000, due to diarrheal diseases. 1 in 9 under 5 children were admitted to health facilities in flood-affected areas. Now, when floods come, everybody gets very worried. I get very excited. I get excited because we at Health Services Academy, then we sit together and then we talk about what is new in this catastrophe that we can go back to the national and the provincial disaster management agencies and to bring out something that we can apply from within our own Pakistani context. There is a word which is called catastrophe. When catastrophe happens, when you write it in Japanese, they don't write alphabets, they don't write words, they have characters. So the first character says danger, and the second character says opportunity. So while the danger is being recognized, as a School of Public Health, we look into the opportunities of how we take it forward. All right. Now the health systems will treat diseases, but the environmental will determine who gets sick in the first place. Because we are not looking at population as a whole, we're looking at vulnerabilities and populations. Now, environment to disease linkages are through direct exposure like air or heat. Then indirect exposure like food systems and vectors. Then there are social vulnerabilities and inequalities, and then health system stresses and reduced resilience. Now in Pakistan, as we're talking about, this global environmental, and we're saying that we need to keep the temperature at about 1.5 degrees or 1 degree rise within the thing. Pakistan has already crossed 1.5 degrees Celsius. By 2050, it is going to rise to 4 degrees Celsius. From 2051 to 2100, well, at least I won't be there. This much I know. It will rise to about 6 degrees Celsius. We are already ranging, in 2025, we touched about 2.1 degrees Celsius rise already in our average mean temperature per day. Now that has a direct effect on the whole thing. We have an opportunity from currently to 2030, we have an opportunity, it's called the acceleration phase, where the system gets into a stress but still can respond. 2040, we will have more endemics, higher non-communicable diseases. And 2050 is the tipping point where it is going to be irreversibility. Doomsday, not yet. Pakistan is going to have to spend more on environmental related diseases. Khyber Pakhtunkhwa is going to have a higher proportion than Punjab or Sindh or. Now you would say, well, Punjab has more than 50% of the population and Khyber Pakhtunkhwa has 15. But it is going to, the system in Punjab is going to absorb a bit, but the brunt will fall on Khyber Pakhtunkhwa, and I'll show you how it increases in the next 2 minutes. It's not a future health risk, and I'm saying it time and over again, it's not a future health risk. It is already shaping morbidities, mortalities, and inequalities. Now, let's look at the climate change context within Khyber Pakhtunkhwa. Now, if we look at the climate context of Khyber Pakhtunkhwa, we're looking at 4 different climatic zones. We have the cool uplands with like Sawat and Chitral and going further up north, touching towards China and Tajikistan. That's where we all go. But then we have the hot and arid environments which are touching around Kohat and Hangu. Then we have hot and humid, the Abbottabad, Mansehra, Haripur, that zone. And then we have the southern zone where we have Karak, D.I. Khan and onward. So these are the 4 zones. So let's keep these 4 zones in mind. We did I would say an operations research and then further helping the government of Khyber Pakhtunkhwa to focus on their primary healthcare facilities and redesign climatic resilient, energy efficient, as well as earthquake proof. Because now the earthquakes in Pakistan are not coming from the depth, they're becoming very shallow, and that is becoming an issue. So we looked at, from a public health perspective, the policies, the strategies, the essential package for health services for primary healthcare, infrastructure guidelines, etc. Khyber Pakhtunkhwa is looking at currently at about 42 million people. But 2030, they're going to go up to about 46. And you would say, so what? That means that we will be having one new Faisalabad in Khyber Pakhtunkhwa. That's the population growth like. Just imagine shifting the whole of Faisalabad into Khyber Pakhtunkhwa in the next 5 years. And then, sorry, I need to go back. And then we are looking at about 11 million women in reproductive health and then about 7 million children under 5. Now, we have 3 kind of facilities over there. Primary health care, the basic health units offering services to 20,000, and then there are the 24/7 operational basic health units to 40,000, and then to 60,000. Currently, we anticipate a different kind of utilization that we expect, ranging between 4,000 to 14,000 women coming to these facilities only if the health facility utilization is at about 1 to 2% visits. Now look at the diarrheal episodes within this primary health at the community level, how it's going to go from 16,000 to about 50,000. The non-communicable disease visits, they're going to range between 8,000 to 24,000. But now here comes the fun part. Now we used the current empirical data, not the daily data, not from the district health information system. We looked at national representative samples from the Pakistan Demographic Health Survey, and we then did an extrapolation against the backdrop of temperature rise. What's going to happen? Yes, sir, I'm going to done in 3, no problem. If you look at the first side, this is your cold area. That's where the mountains are. The zone 1 is where the mountains are, and the dengue fever. Now, who expects to have mosquitoes in upper northern mountains? They are going to increase by 3-folds. Malaria, again by 4-folds. It's going to increase where the hot and humid are, but also in the mountainous areas. The heat illness is going to affect from the current ones in the zone 3 and 4, it's going to increase by 8-folds. Diarrheal diseases, interestingly, are going to go up in the northern areas. That's where we all go to spend our summers. Same goes for leishmaniasis, but the non-communicable, the heart diseases, heart failures, they are going to happen in the dry, arid areas. That's where the whole focus is going to shift. So there is a shift from communicables in the northern areas to the non-communicable in the dry areas. Punjab will take on the volume, Khyber Pakhtunkhwa will take the volatility of the burden. Punjab will be seen as the scale problem and Khyber Pakhtunkhwa as the early warning system. So these is not the 2 provinces, they all both link together. There are rising temperatures, external rainfalls will come. The rains that we had this year, 2026, we're going to have 30% more rain as compared to what we encountered this time. So we need to embrace accordingly. And as far as the climate resilient primary health care is concerned, we're looking at if we want to reduce infections, we need to work around on our prevention strategies for communicable diseases. In NCDs, we need to look at thermal comforts. Temperature is going to be one determining factor. The continuity of maternal, newborn, and child health services will be affected. And we also need to protect the vaccines, the medicine, and the diagnostics. The last thing that I'd like to share with you is that the environment writes the first chapter of every health story. And going forward, the environment will write the very first chapter of Pakistan's health story. And I thank you very much for the opportunity.
Thank you, Dr. Mohsin Saeed Khan, for such a very important and informative presentation about the disease trends and the environmental effects in the communicable diseases and the non-communicable diseases. So now we move on to our next part of our presentations, and it is being presented by Dr. Amreen Sajid Rauf on evidence-based information cervical screening and HPV vaccine. She is a consultant and obstetrician at Warrington and Halton, teaching NHS Trust, UK.
KEMU for inviting me for this talk. Thank you everybody who's come to listen to this talk. I'm one of the consultants working in the UK. I'm a proud KEMCOlian, and it's always an absolute pleasure to come back to my alma mater and give back. So my talk today is on evidence-based information about cervical screening, and particularly removing some myths regarding the HPV vaccine, which started in Pakistan this year in September 2025. So cervical cancer is the second commonest cancer for females. But the good news is that it's a preventable cancer. It has got a big screening program, and now with the HPV vaccine, we can prevent it further women from suffering from later stages of cervical cancer and death. In 2022, globally, 348,874 deaths were caused by cervical cancer. Unfortunately, over 90% of these cases were happened in the low and middle income countries, and Pakistan is one of them. Therefore, the WHO has prompted an ambitious campaign to eliminate cervical cancer. So what are the WHO targets? The targets are less than 4 cases per 100,000 people. How are we going to do them? The WHO has given 3 pillars. First is vaccination, second is screening, and third is treatment. So the first WHO pillar, vaccine. Initially we introduced 2 vaccines which were called Cervarix and Gardasil. We know that HPV is the main victim for causing cervical cancer. There are 200 plus HPV strains, and out of these, 12 are the high risk, which produce the cervical cancer. In 2006, the first Cervarix and Gardasil HPV vaccines were licensed, offering protection mainly against HPV 16 and 18, which are the high risk, and are responsible for 70% of the cervical cancers worldwide. Gardasil also protects HPV 6 and 11, and these cause the genital warts. So the first dose of the vaccine is more effective if it is administered before the first sexual intercourse. So therefore, we are aiming at schoolgirls between the ages of 12 to 15. Currently, there are 6 HPV vaccines available globally. The Cochrane data 218 reviewed 26 trials and found that HPV vaccination reduces HPV 16 and 18 and associated with CIN2 by 99% when administered in females between the ages of 15 to 26 years. So the age is very important. The fact that it is administered before the first sexual intercourse is very important. The HPV vaccination impact study group had a meta-analysis, and over 60 million people found that 83% reduction in HPV 16 and 18 in girls aged 13 to 19 years. HPV vaccination got licensed in 2016, but actually was introduced in 2008 to protect aged group of girls 12 to 13 years. In 2012, Gardasil, which protects 4 HPV strains, replaced Cervarix. So this is the history of these vaccines. Initially, 3-dose vaccines were recommended, and these were reviewed. However, since 2014, 2 doses were recommended for girls under 15 years of age, as the antibody levels were as good as 3-dose regime. In 2019, the NHS vaccination program included boys from 12 years of age as well. People with immunocompromised conditions, however, continue to have the 3 doses. In 2022, Gardasil 9 was introduced as it protects 9 HPV strains. So what is happening in Pakistan? In Pakistan, we lose 8 women every day with cervical cancer. So this is a huge number. I know that there's a big myth that cervical cancer is a disease of the West. No, actually, cervical disease presents very late in Pakistan due to lack of the screening program, and we are losing 8 women per day due to this disease. In Pakistan, fortunately, the first phase of vaccination began on the 15th of September 2025. The goal is to vaccinate 13 billion eligible girls during this campaign. The HPV campaign was set up through the outreach centers, schools, and vaccination teams. Over 60 million eligible girls have already been vaccinated, and this will prevent 1.4 million future deaths from cervical cancer. What are the side effects of the HPV vaccine? Not many serious side effects. Pain, redness, swelling on the site where the shot was given, mild fever, headache or feeling tired, nausea, muscle and joint pains. There are 9 myths, unfortunately, regarding HPV vaccine, which is preventing people to come out with their girls being vaccinated. So people are saying the first myth is pap smear. We are doing the pap smears, so why the vaccine? We need to understand that smear test is a screening test only for precancer lesions and cancer lesions, whereas the vaccine is going to give them protection against the main culprit, which is the HPV virus. People don't think it is safe. However, the WHO has confirmed that it is completely safe vaccine. The third myth is that it causes ovarian failure. There's no association between HPV vaccine and ovarian failure. A Dutch study including 920,000 women and girls has proved that there's no relationship to any reproductive failure of these young girls immunized. People think that it's an autoimmune disease. There is certainly no evidence that it's an autoimmune disease. The other myth is that children are not sexually active. All these young girls are not sexually active. This is, this is for West, where they have boyfriends earlier in their life. However, the evidence shows that the earlier the vaccination occurs, the better the response is. There have been randomized trials showing that HPV still has significant protection even after the first exposure. So later on, HPV can be given and it has some protection, but the main protection is before sexual contact. Another myth is that boys and men have no cervix, so why vaccinate them? However, we know that HPV is linked to 5 different types of cancer: anal, penile, vulval, vaginal, oropharyngeal. So vaccination protects them against all these cancers. Therefore, men need to be vaccinated as well. Boys, I mean. So it's a natural immunity. We all have natural immunity against viruses and bacteria. Why do we need vaccination? Our natural immunity is low, and this vaccine will give us robust protection. The last but not the least myth is that this vaccination causes sexual promiscuity. There's certainly no evidence about this. So in a Dutch cohort study, HPV vaccination reduced the incidence of cervical cancer by 86% if the vaccination was given at the age of 16 years, and reduced the incidence by 68% if it was given at the age of 17 to 19 years of age. In Lancet study, substantial reduction happened in the cervical cancer and CIN3 after introduction of the immunization program in the United Kingdom. HPV vaccination has successfully eliminated cervical cancer in women born since 1st September 1995. What are the barriers of vaccination? The challenges in low-income countries are affordability, sustainability, cold chain capacity, and lack of infrastructure. Globally, 2 in 3 women aged 30 to 49 have never been screened in the low-income countries. Majority are from further low-resource settings. Barriers to participate in cervical screening program are due to system, service, and individual level factors as well. Countries with high prevalence, there is little screening due to lack of funding, lack of infrastructure, and unfortunately political will as well. Poverty is a big factor. HPV positive status causes stigma, shame, and worry. So if there is, people don't want to go for cervical screening, there is a self-sampling program by the WHO as well. So reasons for low uptake is low health literacy, low follow-up, low infrastructure, financial implications, inadequate training of the staff, stigma related to medical examination, lack of awareness, embarrassment, fear of test, and procedural pain. In low molecular countries, one of the methods to overcome all this is to do either self-sampling, or instead of bypassing the cervical screening program, in high-risk patients, we can do what we call VIA, visual inspection of aceto-white areas, and then do treatments. And I've quoted some studies. In the Stampa study showed combined HPV positive and VIA showed a sensitivity of 85.9% among women less than 50 years. So WHO does endorse screen and treat. You see these patients, you do the VIA test, and then you do the treatment. Treatments for pre-malignant diseases include the ablative treatment and the excisional methods. Evidence shows that cryotherapy ablative procedure freezes the cervical cells. However, it has a high failure rate and a recurrence rate. Cold coagulation is better, and it treats up to 4 to 7 millimeters depth. Laser ablation can treat wider areas. Excisional treatment, which includes loop excision of the transformation zone, it can treat up to 25 millimeters. However, if more than 10 millimeters is taken, then there's a risk of preterm labor. So we usually take a depth of 7 to 10 millimeters. That is all. Any questions regarding this? Thank you for attending. So the take-home message is that HPV vaccination is safe, it is free, it has all the myths I've discussed. Please vaccinate for the boys and for the girls, because we are going to prevent 1.4 million girls from this deadly disease. Thank you.
Thank you very much, ma'am. I hope your presentation would help us a lot in busting so many myths that are prevalent in our society about the HPV vaccine. I've got one question. Madam, you mentioned about the vaccination of the males for the HPV vaccine. Is there a specific age for that?
Again, the same, the school age, 12 to 15 years of age.
All right.
And we have been vaccinating the males since 2019. All the boys in the schools are also vaccinated at 12 to 13 years of age. I must say that the program of vaccination is slow in Pakistan, but we shouldn't be disappointed. We have vaccinated a few billion girls. I think the program, if it had been introduced with a lot of counseling for the parents, then probably it would have helped and would have had a better start. But still going on, and I keep coming back, and I'm part of all the campaigns for this HPV vaccine. Women's health is very close to my heart, being an obstetrician consultant, and I'd like to prevent women from dying from cervical cancer.
Thank you very much, ma'am. So now our next presentation would be from Dr. Sohail Yusuf about preventing the preventable, tackling bone infections with modern orthopedics. Professor Sohail Yusuf is a consultant trauma and orthopedic surgeon at Epsom and St. Helier University Hospital, NHS Trust. There is a lot of humming in the background. भाई ये जो HPV वैक्सीन है ना लड़कों तुम्हारे लिए भी है, इसलिए इसको तो सुनो.
अस्सलाम वालेकुम, मेरा नाम सोहेल यूसुफ है. मैं प्रोफेसर नहीं हूँ. उसके लिए बहुत मेहनत करनी पड़ती है इंग्लैंड में, और बहुत से पेपर लिखने पड़ते हैं जो आप सब होपफुली लिखोगे. मैं ऑर्थोपेडिक कंसल्टेंट के अलावा एक ट्रेनिंग प्रोग्राम डायरेक्टर हूँ अगर कोर्स सर्जरी लंदन में. तो मेरा एजुकेशन और ट्रेनिंग दोनों से रब्ता है. मेरा बहुत दिल है कि मैं उर्दू में प्रेजेंटेशन दूँ, क्योंकि वहाँ पे बहुत सी प्रेजेंटेशन इंग्लिश में देते हैं. बट एनीवे विल ट्राई. टैकलिंग द बोन इन्फेक्शंस, preventing the preventable. It's a major problem everywhere in the world, not just in Pakistan. My disclosures are, there may be some pictures you may find offending. Please bear with me. What's the incidence of bone infection? Quite high. It is 1 to 2 in 10,000 as compared to HIV or other problems. It is much more common. There is significantly higher incidence in low class countries where economic barriers plays a huge role in getting medical aid. They are associated with post-operative infections. If you have a closed fracture, the risk of infection is quite low, 1 to 2%. However, if there is an open fracture, that means if your bone is broken and is out of your skin, or there is a skin laceration or skin cut on your limb, there is very high chance of infection because of the contamination. Why does this matter? Because a fractured bone and an infection can lead to loss of your income, prolonged hospital stay, loss of your livelihood, and it can leave mental scarring for the rest of your life. The treatment is difficult, long, and complicated. However, it has to say, many infections are preventable, and we are going to talk about it in the next few slides. What you're dealing with, probably you can understand. This is what a bone infection could look like. There is pus pouring out of a knee joint. If this patient ends up having an amputation, the mortality from an amputation is probably higher than most of the cancer, because there are treatment for the cancer like chemotherapy, which can prolong your life, you can early detection. If an elderly person lose their limb, they are not able to walk, they will develop pneumonia, bed sores, infections, they can die very quickly. It's not a simple problem. This brings to the question why I'm doing this talk. I graduated from Allama Iqbal Medical College, not a chemicalian, sadly. I worked with some great mentors and people, did my training at Sheikh Zayed Hospital, then went on to move to England, and I did further training in Southwest London region, one of the leading trauma centers of the world. I was one of the earliest trainees who did training at Frimley Park Hospital, where we started the multidisciplinary team approach for infections. What does a multidisciplinary team approach means? That there are not just one specialty dealing with these problems. There was a vascular surgeon, an orthopedic surgeon, microbiologist, plastic surgeon, and nurses working together to prevent infection. I have to say very sadly, when I was working here in Mayo Hospital, as well as in different hospitals in Lahore, the infected cases were dealt with the most junior member of the staff. There was very little training. I hope this has changed, because I live in horror. I look back and think about all the operations which I have done, not knowingly what I'm doing, and I have performed this procedure, not making much difference to people's life or their function. Now I run a limb at-risk clinic as a consultant. This is a picture of my team, and we not only look after diabetic feet, we also look after people who have infections and they are limited at risk of losing it because of the infection. The gentleman on the left of the picture grinning is a microbiologist, and the lady on the right is a pharmacologist. It's not just the physicians, medical doctors, or surgeons looking after these patients. We work together to find a solution for better efficacy of antibiotics, appropriate diagnosis of the infection and its bugs, and then cure it properly. It's still a quite different problem to deal with any other issues we deal in day-to-day living. Challenges in Pakistan are much more different. We heard about the environmental changes, the changes about infections, and the different burden we're going to feel about these infections in different parts of our country. Sadly, diabetic foot infections are on the rise. This is because of the poor glycemic control. There's delayed presentation, and that can lead to progression of osteomyelitis. One of the biggest beasts in infections in our country is tuberculosis. Still very relevant, very prevalent, very difficult to diagnose, and cause a lot of issues. Then open fractures. The population is increasing, the infrastructure in the roads is not great, protection is not great. So when you get an injury, it's very common to get open fractures, and as we talked earlier and looked at it, 30% of the people can develop infection if they're not treated properly. Then we are agricultural countries. You can have agricultural injuries. They can lead to contamination of your wound and can cause infection. What are the challenges? In terms of diabetic patient, late presentation, limited access to multidisciplinary team as compared to the other parts of the world. Tuberculosis, again, low index of suspicion, delayed diagnosis, delayed presentation, delayed treatment. Then comes the pivotal point of my presentation, the local bone setters and people who are not trained orthopedic surgeons. And they are dealing with these injuries without much knowledge and education. So I'm going to focus on mainly this major problem, because infectious diseases and tuberculosis is slightly different from my day-to-day practice. I strongly believe it's a preventable problem, and that's why I'm saying my title of my talk was Preventing the Preventable. It can only be prevented if we catch them early. The common thread is in all the previous slide was delay in presentation, delayed in diagnosis and delayed in getting treatment. Bone infection is not often inevitable, but the results of missed early opportunity. Early referral, timely debridement, and MDT-based care are essential, and I think we need to focus on it. This is a picture not very far from here, although we think the bone setters are in the rural areas. This is cantonment area in Lahore. There is a camel walking nearby a bone setter shop. The light on the back is over an X-ray machine, so they have made progress. So at least they can do an X-rays. But you imagine you have an open injury and you go there and you get your beautiful oils on that skin, which seeps through your skin wound and goes into the bone. That's what could happen. The non-sterile management of open fractures, tight splints, killing the circulation, and eventually delayed presentation to the hospital and treatment can cause chronic osteomyelitis. That means the infection is not now inside your bone. Once the infection is in your bone, you need a minimum of 6 weeks of IV antibiotics, if not 2 years of treatment, just without operation. This brings to a pertinent question: why do patients choose to go to the bone setters? It's low cost, easily accessible, it's a cultural trust. Distance from the hospitals in many parts of the world is quite significant. And the limited awareness of the risk, not only to the people who are going to the bone setters, but I also believe the bone setters have limited risk of what they're doing, although they may be doing the treatment in good faith. Evidence in literature is very sparse. Most of the studies are retrospective. Very few large-scale studies with large data numbers. However, I like this study from 2020 from Jamshoro. Up on the right side of the screen, you can see there is different reasons for going to the bone setters, which is interesting. Right at the bottom is forced by someone to be taken to the bone setters. This is not a problem just in Pakistan. This is a recent editorial in one of the largest journals of trauma and orthopedics in the world, as of May 2025. And they identify a large proportion of the world are still seeking treatment from the bone setters, and the complication rates are staggeringly high. When these people who have gone to the bone setters and they come to us in the outpatient settings or in our clinic, we always tend to blame them. We frequently tell them they were fooled, they went to the bone setter, they should have come to us straight away. It's not their fault. I strongly believe it's not their fault. The circumstances around our health systems force them to go to the bone setters, or people who are not qualified. So I urge you, when you grow up as doctors, surgeons, have compassion for these people. They really need your help. They are in a very difficult state. They have a difficult problem. Their job, their life is online. Some wise person said, with greater powers come greater responsibilities. Then the other cause is iatrogenic causes. When we say iatrogenic, these are the people who had operations earlier on by a surgeon, but again, with the limited knowledge and understanding and medical training. They use substandard implants because the sterilized implants are very expensive. There is streets and streets, factories in Sialkot and Gujranwala, from where I came from, where the people are making these implants at home. They are made of very corrosive materials. Theater sterility is poor. And often these people end up having infections. This is one of the cases which has been discussed with me only 2 weeks ago. Because of the poor metal selection and poor bone coverage, the metal is now outside the skin. This patient is going to have a very long course of treatment. This is an X-ray of a similar nature where all the holes of the plate has been used. The screws are inside the fracture. Fracture is not uniting, and it's going to fail because of the infection. Again, it's a real-time scenario. Not very far from here, discussed with me a few days ago. What are the early detection signs which can help to save the limbs? Listen to the patient. As a clinician, we all must listen to the patient. History tells you a lot of things. What happened during the injury, what happened immediately afterwards, what happened after the operation, was any complaints of redness, swelling, fever, warmth around the skin. They all can give clues to an infection. So a thorough examination then you can request appropriate imaging to make diagnosis. In the tertiary referral hospitals, I hope there will be MDT setups now, because these patients do require a holistic approach to manage these problems. One specialty, an orthopedic surgeon, may not be capable of dealing with a complex problem, and it requires a multidisciplinary team. The other problem is use of antibiotics without knowing the bug or what is the bacteria which is causing the infection. Broad spectrum antibiotics really make it very difficult for us to get rid of those bacteria from the metalwork, because they form a biofilm which is very strictly adherent to the metalwork, and although you give treatment antibiotics, sometimes you do an operation, it stays inside the system and cause further problems. Thank you. What are the practical solutions? My suggestion is regulated implant procurement. Very hard to do it, but we have to do it someday. Population is increasing, number of people who are falling from the motorbikes, from the trees. There has to be some procurement, and they have to stop those implants to be poorly made and poorly sterile. Minimum training standard for orthopedic surgery, I have to say, while I was training here, there has been a lot of progress and improvement. I hope it will continue to flourish. Affordable trauma and fracture services, again, there seems to be emphasis that there should be more basic health units. I hope this will improve as well, and that is really required. Public awareness and education, it has to come through you. As I said, if a patient comes to you, treat them well, they will go to another person. That's how you will change the system. They will tell me, doctor treated me with respect, compassion. I think you should go to the doctor in the main hospital. That's how we're going to change the public awareness and education. The referral pathways for traditional bone setters in Ethiopia and Nigeria, they had a huge success. They, rather than fighting with people who were doing these treatments, they tried to train them and educate them. This has changed the infection rates significantly. Collaboration, not confrontation. That's my message, and I think that should we be focusing on. In old times, the wound treatment was dilution, and that was the solution. But now it has changed. There has to be appropriate antibiotics after recognizing the bugs. Thorough debridement, as I said, multidisciplinary team approach, and that's how you can get rid of a chronic infection inside a limb. I will very quickly show a case to you. I know these could be slightly gruesome pictures, but this is a diabetic lady who has an open fracture, has very poor vascularity. This requires emergent management. This treatment in a plaster is going to fail. This patient is going to die of sepsis. And this is her fracture, this is her limb. You cannot do an operation on this leg. What are you going to do? I talked to my vascular surgeon. We realized that she has very poor blood supply. First thing we did, we revascularized this patient's blood supply. The next thing we did, minimal invasive operation. We didn't open the skin. We went from the knee, put an implant using the modern technology, modern orthopedics, and that's how we stabilized this fracture. The fracture allowed us to mobilize this patient. This is 3 months later. The patient still has her leg, and she's walking on it. The other modality which is helping us to tackle infection in West is a bone cement, which has antibiotics. That antibiotics locally can go into the bone area and work very efficiently for about 21 days and get rid of the infection. In my own practice, it has significantly reduced the inpatient hospital stay as well as antibiotics requirement. Another case, this diabetic person stood on a nail and thought there's nothing significant, developed infection. The GP gave him antibiotics. When he came to us, we noticed that the pus is now tracking down to the foot. And within a day after giving antibiotics, this was the progression of his infection because he has very poor physiological reserve. He's immunocompromised. His X-rays were normal, but his MRI scan showed changes in the bone consistent with infection. That's why the modalities like MRIs can help to identify infection at an earlier stage. This patient required surgery. It required complete removal of the dead tissue. Otherwise, you cannot get rid of the infection. We removed the part of the bone in order just to try to save the foot. This is the bone cement which we put inside the bone and left it there for a couple of days. It started eluting antibiotics, and this is the same patient 3 months down the line. The foot is still intact, the foot is now healed, and he's walking on it. This is the evidence for this osteomyelitis treatment with bone adjuvants containing antibiotics. This is probably the future of management of bone infections. My take-home message is most bone infections are preventable. A major contributor in our society, sadly, poor surgery, and the bone setters, we need to educate them. Early detection can save limbs. We need to find strategies to deal with this. MDT care is the future. Antibiotics, stewardships is essential. Please do not give blind antibiotics. Thank you very much. Any questions? Mm.
So what are your clinical practices? Will you take the sample for the pus that is leaking from the wound, or will you take the sample of bone, which the osteomyelitis infection is going on? So what your practices have done? Because it's very difficult to catch the bug and to treat it with a justified antibiotic.
Absolutely spot on. In Oxford, they have a bone infection unit, which is one of the world leading bone infection centers. So they have recommended 7 samples. It is expensive. Every time you have to use a new blade. So you start from the skin, you go down to the muscle, you take the sample of the pus, you take the sample of the bone, then you do a deep curettage and clean, then take a sample of the bone again, and send at least 7 samples. Because, as you said, that is the key. Once you have identified the bug and you can give them appropriate antibiotics, then you can manage it more effectively. It is difficult, but I believe you have to stop antibiotics at least 2 weeks in advance unless the patient is septic. Now, there are some machines which can still detect some bugs even though you're still on antibiotics, but 7 samples is my usual routine. We follow the Oxford guidelines, and that's how I manage to identify the infection bugs and treat them appropriately. Yeah.
For an excellent presentation about the bone infections, and the quality and the training of good orthopedic surgeons cannot be overemphasized. So now we move on to the next presentation, and this is being done by Professor Amir Afzal, who's the Professor of Surgery at KEMU, and the presentation is about outcomes of the thyroid surgery in a high-volume tertiary care center, a clinical audit in accordance with ATA guidelines benchmarks. So,
thank you very much, Arshad. Professor of Surgery, Non-Surgical Ward. Today I am presenting an audit of a year of non-surgical ward, but it's as well as it's a contribution to the teachers and surgeons who has made the thyroid surgery so easy for us to understand and to perform and safe for the patient. So let's start with the name of Allah. Bismillah ar-Rahman ar-Rahim. So if we talk about the historical footprints, so thyroid is not a new disease, it's a disease of ancient era. So endocrine malignancies, the commonest disease is thyroid cancer. Goiter has been recognized before 2700 BC, and Abul Qasim al-Zuhrawi was the first person who described the thyroid diseases and treated them. Then Theodore Cocker, the father of the modern thyroid surgery, who gave the new avenue for the thyroid surgery, and he did 5,000 and more thyroid surgeries in his lifetime. And if we talk about the Pakistan, the first surgeon, Professor Amiruddin, who was the pioneer in the thyroid surgery, bloodless surgery, safe surgery, and he followed the footprint of the previous ones. Then Professor Zafar Azhar Shah Sahab, who gave the new shape to the thyroid surgery. He gave the concept of bloodless or free field surgery for the thyroid, as the hemostasis is concerned. He used to give a concept of hemostasis while performing surgery. So he revolutionized the thyroid surgery in Pakistan. Following him, Professor Khaja Muhammad Azim, who is a master of the thyroid surgery, is known as in this area, and who followed the legacy of Professor Zafar Haider Shah Sahab and continued till his retirement in Mayo Hospital. And now this is me following the footsteps of my teacher, Professor Khaja Muhammad Azim. So, how this all advancement in the thyroid disease management took place. Many factors they were involved in its development, like introduction of the technology in the surgical field, better understanding of anatomical structures in the neck, new development of the investigations, evidence-based guidelines, also clinical and practical demonstration of these guidelines as a tertiary care hospital, and close follow-up along with the multidisciplinary team. A dedicated and skilled surgical team, of course, required for the good thyroid surgery. We performed 7,000 cases in the last 5 years, in which 585 cases were of the thyroid in nature, malignant or non-malignant both. From July 2024 to 2025, we have done 110 surgeries on thyroid, both in benign and malignant cases. In this study, we have analyzed the clinical and surgical outcomes of, and especially post-operative complication, hospital stay, surgeons and patient satisfaction, and outcome, whether this outcome was according to the international, like American Thyroid Association or not. This was the main purpose of this study, to assess the pattern of the thyroid surgeries and diseases and post-operative outcomes in a high-volume tertiary center. Compare these findings with the American Thyroid Association guidelines, who has recommended. The objective was to determine the proportion of total thyroidectomies, how many total thyroidectomies were performed in accordance with the American Thyroid Association, lobectomy, hysterectomy, total thyroidectomy along with the neck dissection, modified, radical or other type of the neck dissections that we perform, and evaluate the versus benign and malignant pathologies. That was also a part of that study, and measure the incidence of post-operative complication. That is the most important, because thyroid surgery carries many complications like hypocalcemia, hoarseness, or even post-operative tracheostomies, nerve because of the bilateral recurrent nerve injuries, infections, and patients' permanent voice changes, and the reopening of the patients. And hospital stay, how many days the patient stays in the hospital after the surgeries, and we interpret and compare the result in the light of American Thyroid Association guidelines. We have certain difference in the presentations of the patients, and definitely we have difference in the results as well. The main factor is the very late presentation of the patients. The patients who present to us who has very advanced malignant disease or very huge benign thyroid diseases. Like, despite advanced local diseases, the important thing is, because usually in Pakistan, the patients do not bother about what is going on and how we are looking. So they present very lately. So, but in spite of this late presentation, we tried to minimize the post-operative complications that may be comparable with the international data, where the disease is early and other modalities of treatment, they are very readily available. Many investigations and other treatment modalities, they are available there that we don't have in Pakistan. The same goes for the benign disease, and the presentation is huge giant goiters. Why we have some lower complication rate? Number one, I have told you the legacy that was carried out. Excellent outclass surgeons, they taught the students on the table how to perform the surgeries. So the first one is the compulsive, complete and ruthless hemostasis. Because if the tissue is stained with the blood, you can't even identify the structures, normal structures. Second one is we don't perform surgical dissections, we perform anatomical dissections. Like we preserve all the anatomical structures and excise the specimen. And operation is done usually on the permissive hypotensive anesthesia is used, and recognition of the structures, as I have told you, anatomical dissection, identification of the structures, parathyroid, recurrent nerve, external branch of the superior laryngeal nerve, they are all identified and saved. And we do not just expose the nerve, just it's going okay, it's going into the tracheoesophageal groove, so I have seen the, no. Punjabi mein kehte hain bure de ghar tak pahunchana. So we take the nerve when it enters into the larynx. We identify it and we save it. Now if we look at the data, total thyroidectomies, they are more performed in our setup because the disease is very advanced. They are 88.2%, and lobectomies, they are 31%. Gender, female gender is more common, 89.1% female patients and 10.9% patients only male. So these are the graphical presentation. Now the combination of the total thyroidectomy with the block neck dissection, they were also performed, in which radical block neck dissection were performed in the 75% patient, and in the 25% modified block neck dissection was performed. Same is the, among the 110 patients, there were 83 patients, they were benign, and rest of the patients they were malignant. So 25% malignant contribution to the study. And if we talk about the malignancy type, majority of the patients, they were papillary carcinoma, 78%, and rest of the three types, follicular, medullary or oncoplastic cancer, they were almost 8 to 7%. So this is another representation of the complications, in which nerve injury or permanent hypocalcemia. Our patients did not show any permanent hypocalcemia, but in one patient, 0.9%, we have nerve injury. That is in accordance with the ATA. Hospital stay, majority of the patients, 50% of the, more than 50% of the patients stay only 1 day. 40% almost in second day they are discharged, and the rest of the patients more than two days. Their stay in the hospital was longer because they multiple lymph node dissection patients or huge thyroid. Now, this is the most important part. I want to show you the level and standard, what type of patients we receive in our outpatient departments. These are all malignancies. These are the benign diseases, goiters, huge goiters, humongous. And metastatic lymph nodes with the external appearance, how they look on the surface marking, the lymph nodes are so large. With the distant metastasis, follicular neoplasm, Pandred syndrome. These are the operative field pictures, in which you can see that darkly stained colored lymph nodes, they are present in the neck. They were all cleared very beautifully. These are the pictures of various patients who underwent into the thyroid surgery. These are the benign diseases, multinodal goiter. And retrosternal goiter is not uncommon in our setup. Many a patient presents with the retrosternal goiter. Recurrent thyromatosis, even the superficial, the subdermal lesions, they were also present post-operatively. Pyramidal lobe. recurrent goiters, that is another presentation to our setup, because Mayo Hospital is a hospital we say never no to any patient. जो भी आता है वो हमें लेना ही पड़ता है और करना ही पड़ता है. So there is no other place for the patients who has recurrent goiter and म्यूल है जो. These are the pictures of specimens. Recurrent laryngeal nerve. You can identify, yeah, marker है हमारे पास. These are hooked. So after, during surgery, when it is adherent to the tumor or it is struck into the tumor, at times we have to hook the nerve with the nerve hook, but with the predictable safety. Non-recurrent laryngeal nerve, another situation we have got, very difficult to save the nerve, but still we save it. 1% chance, so we have 4 in the last 3-4 years. Ectopic goiters as well. Malignancy in the thyroglossal cyst. Benign diseases leading to the, there was a concept when there is a malignancy, there will be hoarseness, but वो कहते हैं कि there are certain patients who present with the hoarseness, but the disease is still benign. In these patients, after picking up the nodule, compressing on the nerve, lead to the normalization of the voice. हम भी नहीं मानते थे जी कि voice hoarse नहीं होती, but it still got hoarse after compression. Now, this is a me-incision lobectomy that is done in Mayo Hospital. We used to do lobectomy, ischemectomy in young patients who do not want large scars on the neck. So 3 to 5 centimeter incisions are made, and the more than 5 centimeter or 6 centimeter the nodules हैं, they are taken up from the this hole with the predictable safety of parathyroid as well as with the both nerves. This is a new modality in Mayo Hospital. I think very less people they are doing like this. Cosmetically, this is acceptable incision. Thank you very much. Questions? Benign diseases, we are performing multidisciplinary meetings in our department. In these cases, definitely we have huge thyroid benign diseases. We used to perform multidisciplinary team involving all the radiologists, but anesthetists, they are not involved at the time of MDT, but they are pre-operatively assessed patients by the anesthetist, because if the airway is difficult, then they have to plan the how to maintain the airway of the patient, because we have certain gadgets over here like laryngoscopes, fiber optic laryngoscopes, they are available in Mayo Hospital. They can perform intubation with the help of that laryngoscope. So that's why pre-operative assessment is independently done by the anesthetist, but the other large size tumors, they are discussed in the multidisciplinary team in our department. And it has a definitive role in the better management of the patient and better outcome of the patient. Thank you very much.
Thank you very much, Professor Amir Afzal, for your tireless services to the underprivileged strata of our society and making a benchmark in thyroid surgeries. If there are any questions regarding the previous presentation or any other presentation, because Dr. Amreen is going to respond to one of the queries that have been referred to us. Please, madam.
So one of the questions I've been asked is where to get vaccinated in most government regimes, as it focuses, the vaccination focuses under 18-year-old girls. In the United Kingdom, we do it in
vaccinate boys and girls both around the age of 13. I think this similar is the case in Pakistan. They are being vaccinated in schools. Whether they are vaccinated inside schools or in vaccination centers, I think that doesn't matter much. In Pakistan in particular, the thing which matters is that the parents should be fully counseled about the vaccine. They shouldn't feel that they are forced into it. They should be fully prepared what the vaccine means. And as I explained in my presentation, all those 9 myths regarding the vaccination should be cleared in the minds of the parents and in the minds of those girls. The girls are, quite young, but if the parents are fully counseled, then they will get their children vaccinated and convince others to get the vaccination as well. Thank you. I hope this answers the question.
All right. So that concludes the session. And now we will be moving on to the certificate distribution. But first of all, let me thank all the panel who have traveled all the way from different corners of the world, highlighting pertinent issues, relevant problems of society, and educating us. We thank you all wholeheartedly for educating us. Now, I would request Professor Mohammad Moeen to please come on the stage. Professor Khalid Rahman Yusuf, please join us on the stage for the certificate distribution. So, the first certificate goes to Professor Mohammad Moeen himself for doing an excellent presentation for early onset retinopathies. Then we'll deliver the certificate to Professor Junaid Sarfraz Khan. Because he is not here, if Professor Mohsin Said please could come on the stage and receive the certificate on his behalf. Thank you, sir. So you have to do the honors for Professor Dr. Shahzad Khan as well. Then Professor Mohsin Said Saab himself for being a brilliant team player, receiving 3 certificates honors part of his colleagues. Then Dr. Amreen Sajid Rauf. Then let me request Dr. Suhail Yusuf for his excellent presentation on the bone infections. Then Professor Amir Afzal for his untiring services, and acknowledgement for his services. Can I request Dr. Muhammad Aslam, Chair KEMCA, to please come and receive a certificate? Not here. All right. Then Professor Ahmad Uzair Qureshi, please, sir, if you can receive a certificate on his behalf as well. Last but not the least, it's myself, Dr. Muhammad Asadullah. So now we conclude this session and